And that being said, thank you so much for being here. And over to you, Lavender.
Thank you so much, Awor. You really set the pace for this important discussion, and we're really looking forward to, the different insights from our panelists. But before we get to the panelists, let's have Benta, our lead researcher, give us the key findings, the outcomes, expectations of this rapid analysis report that we drafted with together with PHM and other partners. Over to you, Benta. We look forward to your findings.
Good morning, everyone. I would like to begin by thanking all of you for joining us today for this launch. And I'd like to thank the members of the Circles of Conscience in the counties that we visited for their organization and willingness to give information and organize communities to help us in data collection. And I would also thank our partners who are also here today, starting with PHM. Thank you all for being with us and taking part in the research, and finally coming up with this beautiful report that we're going to analyze today. So I'd begin by noting that we did our research in 5 counties, that is Wajir, Garissa, Tana River, Kisumu, and Kilifi. And in all those counties, we noted that there were very different dynamics on the accessibility and use of NHIF, which of course we're going to unpack in the report as we progress. And of importance is that we did this research to find out how the National Health Insurance Scheme was, just to find out whether it was meeting the needs of Kenyans and whether it was propelling us towards realizing universal health for everyone. And importantly, we also wanted to see if there are ways in which NHIF can be supported to be able to realize this right for all Kenyans. So maybe before I go to the main findings, I'd like to note that the findings were, in some places we found that, Kenyans were happy with NHIF. Some of them thought that it was really affordable, easily accessible. The service was good. Mothers were happy that they were able to get they were able to benefit from the Linda Mama program, which allowed them to access free maternal services in all public hospitals. And but the broad finding is that majority of our respondents were not happy with NHIF for the reasons that I'm going to point out. And of course, we want to note that we are happy that we were able to interact with both sides of the coin. And maybe to go through our major findings in the report, I'll project so that we're able to go through them together. Maybe Billy, you can allow me to share my screen. So the first finding, as Billy is setting me up, is that we found that 94% of our respondents still have difficulty accessing public and private facilities using NHIF, despite being paid up. And the main argument was that the hospitals felt that there was a bit of delay in getting money from NHIF after they had offered services. And in some hospitals, from the testimonies in the report, you'll see that some hospitals felt that the amount that was given by NHIF for outpatient services was too little. And that made them turn away patients who came while using the NHIF card. And then the second finding was that the mandatory contribution of 500 shillings was considered to be very high by about 48% of the respondents who we interviewed and collected data from across the 5 counties. And of course, in some counties where, I mean, in all counties where employees, especially government employees who depended on the county government to remit on their behalf, they said that there was a delay in remittance by the employers, and this made them not have access to these services when they went to the hospital, because as much as the money has been deducted from their pay slips, they could not access the services because the money had not been then remitted by the employers to NHIF. And this was a concern that was raised by employees, county employees specifically across the 5 counties which we visited. And then of concern to us and also the respondents in this study was that the NHIF, knowledge of NHIF and the services that they offer was very low, because most of the people who seem to know what NHIF does and the services that they're entitled to were those who are in formal employment. And this because it is a statutory requirement that they register or enroll with NHIF. But as for the other people, it was difficult for them to clearly point out, what NHIF does and why it is important for them to enroll with NHIF and what their entitlements were after they had registered or enrolled with NHIF. And as Ayecha has pointed out, is that in some counties where poverty levels were high and people could not really afford the 500 shillings, the communities felt that they were not involved in, the process of coming up in a remittance structure. Because in some of these communities, for example, in Wajir, they noted that if the government could find a way to, for example, take their livestock or animals, maybe they could take a cow to NHIF offices and then they would enroll them for the whole year, then they would, easily enroll the 500 shillings or money, then you cannot have access to these services, even though you have resources which can, be used to help realize or give access to NHIF. So that is a brief summary of our findings, which you'll also find in the report, which will be uploaded immediately after it is launched. I'll go to the key recommendations on what Amnesty Kenya and PHM recommend after, going through, traversing the 5 counties and getting people's views on how or what they feel about NHIF. So the first one is, we recommend that NHIF adopts policy reforms that, strengthen corporate governance and reduce corruption rates. For instance, we went to Wajir and residents were pointing out that hospitals were forcefully admitting them, because they felt that if you admit a patient, then they will receive more money from NHIF. And from where we sit, these are some of the corruption and corruption instances that NHIF is supposed to, have policy and strengthen their systems to curb. And of course, we also recommend that the monthly subscription of 500 shillings be reduced to 500 shillings, which I think the government had pointed out that they were going to reduce this amount, and we're still hopeful and recommending that this amount be reduced to 300 shillings to make it affordable to more people. And then, of course, we recommend that public education be done. I mean, that investment in public education on NHIF and the importance of NHIF be put out there for people to know, so that they can benefit and have access to these services. Then we also recommend that NHIF expand the number of accredited facilities across the country, because in some counties, as much as NHIF was willing and ready to offer services to people, there were no facilities that could offer these services. So for example, in a county like, I'm sorry to keep using Wajir, but it is a vast county. And if you have just 2 hospitals which are located in town, even if NHIF offers these services, very few people will still have access to these services. So maybe as a recommendation to the government is that, have more facilities and also encourage NHIF to accredit more private facilities which are closer to the people, as also the government finds a way to, have health facilities closer to the people. And then we also recommend embracing of alternative payment plans, which are which take the community's needs into they consider the community needs. And as I have noted, for example, in Wajir, people were very happy. They were like, we can give 3 goats and have the whole family insured for the whole year. And I'm sure that is not something that is beyond, the government or NHIF to do. And also, we encourage the Council of Governors and county governments to embrace and come up with a county health coverage scheme. I'll give an example of Kisumu County, which has the Marwa health scheme, which is basically health cover that is paid for the government for the financially vulnerable people in the county. So if other counties come up with such a scheme and support the national government in their UHC plan, we'll have so many people covered in this by NHIF and also having access to health insurance. Then also our final recommendation to the government is ensuring that the money that is generated from hospitals and other health functions should be rechanneled back or reinvested in the health sector. And also this would include, supporting NHIF with more budgetary allocation and ensuring that they have enough money or enough funds to run and offer services to Kenyans. But importantly, of course, as a recommendation to NHIF, we recommend that they have workable schemes and systems and a way that Kenyans can easily communicate their challenges and have their problems resolved in good time. And I think in brief, that is the summary of our findings and recommendations in this report. And I will leave the rest to the panel to unpack. And of course, we're looking forward to your comments on what you think and any other recommendations that would be helpful to ensuring that all Kenyans have access to health, affordable, not just health services, but affordable healthcare in Kenya. Thank you so much. I will invite Zaina to take over and invite the panel for the in-depth discussion of the report. Thank you.
Thank you so much, Benta. Thank you to all of you who have joined us today. It is a timely conversation. It is a conversation that affects each and every one of us individually and collectively. Amnesty International Kenya has endeavored to do the research, but what does it mean to the common mwananchi? What does it mean to the policymakers? Today, we are joined by 2 panelists who are experts in the field and who are going to give us more insights and also contextualize this discussion around what is happening in the country and what this means for us going forward. So we are joined by Dr. Ravi Ram from the People's Health Movement. Dr. Ravi is a specialist monitoring and evaluation specialist, joining us today, and PHM is also our co-publishers. Karibu sana, Dr. Ravi. We are also joined by Dr. Simon Kigondu, the president of Kenya Medical Association. He's an obstetrician and gynecologist, and one of board members at Amnesty International. So I will start with you, Dr. Ravi. From what has been presented, what do you make of this report, and what do you think the impact will be on Kenyans?
All right, thank you, Zaina. Just to check, you can hear me all right?
Yes, we can hear you loud and clear.
Okay, great. Let me just start to say, very pleased to see this report and its analysis, and a big thanks to Amnesty Kenya, and especially Beta, Zaina, and Lavender, who have been instrumental in this study. Very briefly, 2 points from a people's perspective. Number one, we have to emphasize that primary healthcare is the foundation of functioning and equitable health system. That's been established for the past 50 years. And I bring it out now because whether it's NHIF or UHC in Kenya, it's largely been ignored. And so that's something we need to focus on. But then turning to some of the points that have been raised, we fully agree that publicly financed and provided health services are essential to realizing the right to health. And at the very beginning of war, referred to Chapter 43, the Kenyan Constitution, which guarantees the right to health to all Kenyans. Sort of a bit of background to this report. And I think we can start with, why did the UHC pilot fail in 2018, 2019? All 4 counties declared it a failure in 2020. And even the national government and its civil society international partners couldn't disagree. Essentially, the biggest issue is that, well, let's take aside the question about politics and the role of the national and county governments in health. But it's down to that a subscription model is simply not appropriate for Kenya. And that's largely true across Africa. It's basically designed for a middle income European country, and then it's been imported and in some ways opposed by technical experts from international donors and banks. Specifically, a subscription model, which means people pay out of pocket in order to be part of a program, it doesn't consider the 190, which Zaina has just referred to, the informal workers, people with irregular income. And let's not forget that many of our nomadic tribes have really no cash income through the year. And apart from that, in a cultural sense, insurance is not a service that's recognized, not just here in Kenya or East Africa, but all across the world. Economically marginalized people do not pay for insurance. That's just the reality. And yet we're using an insurance model. So why is the current government repeating a failed UHC model that was basically borrowed from the previous government when the 2 governments are theoretically in political opposition? It comes down to that UHC, NHIF, is being used to extract funds from the public without being seen to be a tax. And secondly, we know that there's low accountability in NHIF. That raises questions about how these newly extracted funds will be used and opens the potential for misuse. I know Lavender also talked about how and this report deals with corruption. We don't want to be seeing increase. We want to see better accountability and better use of funds. And on that way, I'll also just recall that there was a clear NHIF scandal in the coalition government 12 years ago. We need to recognize that not much has changed in terms of accountability. So what do we really want to see? Number one, let's keep our eye on the ultimate goal. We want equal and high quality service for all Kenyans. And that doesn't matter what level of income, whether rich, middle income, or the poor. And the poor are the majority of the Kenyans. To get there, you see interim steps. If we have NHIF as the model, let's make sure that it's being used to subsidize the lower income population. Try to extract any kind of fee, 500 bob, 300 bob, 1,000 bob. It's only going to push people out of the system and get some minor contributions when people are able to pay or when they have a need. And they find out that they're still excluded from services. And number two, we need to make sure that the accountability is in place. We need to make sure that NHIF does not have favorable payment schedules for private healthcare providers. As Bent has just emphasized, we also need to make sure that the funds that NHIF does have are used to improve the public health system, and make sure people aren't diverted away from the public health system because of low quality or inaccessibility or the unavailability of health workers or of medicines, and then push to the private sector. But ultimately, in order to reach the higher level goal, we need to move to a tax-based finance model for the health system in Kenya. Just a few closing points then. Let's remember UHC has shifted in time since 2015, when it was originally a promise of universal health and to reach that universal healthcare services. And now it's a question of money, which is just a distortion of the health policy questions. NHIF does remain a tax on the sick and the poor. Those of us in the salaried sector who can't pay, we may get some benefit, but we are a small minority in Kenya. And then let's recognize that the right to health equity depends on tax-based financing. The current fight to save NHIF is part of the struggle, and it's really about accountability around NHIF. The larger question, though, is how to ensure that our low-income brothers and sisters have it and realize that right to high-quality health services from their governments. And I'll pause there and come back to the discussion. Thanks very much.
Thank you so much, Dr. for your very insightful presentation. I would like now to go to Dr. Simon Kigondu. First of all, just give us your perspective. What do you make of this report? And number two, considering the context that we are living in terms of statistics, Kenyans, we are about less than 30% of Kenyans who enjoy insurance, whether it's from NHIF or the private insurance. Of that less than 30%, about 85% is covered by NHIF. But we recently saw patients being chased away from hospitals, being told that, you know what, your NHIF cannot extend services to you because hospitals were not paid. So Dr. Simon, as you give us your insights about this report, what then can Mwananchi do in this context? Thank you.
Thank you very much. I hope I'm audible.
Very audible. Gary.
Thank you very much. I want to thank the people who did this particular research, specifically the Amnesty International team and PHM. And I think it is very timely. And it comes at a time when Kenyans are now getting more involved in conversations on issues that affect their life. Previously, if we go back several years ago in the advent of, for instance, the doctors' strike, part of the difficulties that doctors were facing is the ability of Mwananchi to see the relationship between health financing at a national level and service delivery, especially in health. So a lot of the times, the people who are blamed for poor service are, for instance, the doctors. And the reason for that is because the doctor is always the one in touch with the patient or any other health worker. And therefore, it's an easy target to blame. But as time has gone by, we have actually seen some of the issues that affect Mwananchi that are invisible. For instance, some of the taxes that are being proposed. In health, back to healthcare, health is a right. When a patient goes to a hospital, their aim is to get better and go back to work. How at the end of the day, they want the highest possible care. They don't care who is paying, who has been employed, who is employing. The aim is to have healthy individuals who will go back to work. Yeah, and therefore we need to start demystifying these concepts of one, and maybe some of the mantras should be: there is no public patient, there is no private patient. The patient is the patient. Secondly, we also need to demystify there is no, and hence the issue of public facility vis-a-vis private facility. So those are important concepts to note. On issues NHIF, our association as doctors has always, and I think Ravi has touched on that very well, has always advocated for what is called a tax-funded healthcare model. What does that mean? A lot of people are confusing NHIF with healthcare financing. And that is evident from what has been said earlier about Linda Mama. So Linda Mama was a program started previously by the previous government to help mothers who may not be able to pay for the services of delivery, antenatal care and delivery. Is Linda Mama NHIF? No. NHIF was used as a vehicle through which Linda Mama monies, which is actually a concept of what is called tax funded, can be channeled to the facilities that are providing that service. So it is important to differentiate this. So when people talk about Linda Mama and NHIF in the same sitting, they are talking about two different models of healthcare financing. Yeah. And we also need to understand that NHIF is not a payment model. NHIF is a vehicle. Now, the difficulties we are having is the government wanting to say that NHIF is the way of government providing health services, yet it is only a vehicle. Looked at critically, NHIF is a members club. It is an insurance. It means that for you to get a service under NHIF, you needed to have paid something. You see, that is almost like an insurance scheme. Whereas the role of government is to provide healthcare for all. And as you have seen, those some of the research done in Wajir and Asal areas. So what happens if someone cannot pay? So we need to look at it probably slightly different. And NHIF was a model through which funds could be channeled as one of the ways of financing healthcare. Do you know what the biggest model of financing healthcare in Kenya is currently? Out of pocket. What we pay for out of pocket is more than what is paid for by both insurances and by both the National Health Insurance Scheme. And therefore, even as we discuss NHIF and the various models, it is important to, as Ravi has said, to see how we can adopt a model of tax-funded model, whereby NHIF can be used as the vehicle through which these monies that come from government go through. For instance, if I think of at the top of my head, if in a health fund, a health tax, for instance, that 1.5% or 3% is put wherever it is collected from, then that can be used to pay for all health services. The payment of 1,700, 500, and others, like civil servants pay a bit more, they pay like 5,000 a month, can be an additional safety net in terms of additional services, because sometimes at the current stage where we are, it may not be possible to provide all the services, health services that are needed. But because the government has now chosen the vehicle of NHIF, then that understanding is important. And you've seen the complaints. Why should someone, for instance, who has paid 500 be given less healthcare than the one who has paid 1,500, or there are other schemes as such? It's because the model they are using is a model whereby the amount you pay is the amount that determines the level of care you get. So we need to get these aspects correct, and then we can now ensure that healthcare is available for all. Now, coming to this report, the report is excellent, and if all the recommendations were adapted, indeed, healthcare provision would be much better. A lot. What caught my attention is the delayed remittance, for instance, by employers. Yes, that has happened. If you are, and again, as you see, it's a remittance model. If the 500 was not paid, your card does not work. So a lot of, we would need to have those who remit NHIF and remit on time, or use the annual subscriptions that NHIF had, so that the members who are being paid for are not denied services. Another recommendation, as I see, was that the number of accredited facilities that will increase NHIF coverage, and also the services provided. This is important because you may find, and I worked in Isiolo sometime, you may find there are no facilities within a wide range, there are no government facilities. Maybe there is a private facility. We go back to the model. There is no private patient, there is no, the patient should be attended at that facility. Finally, there is the issue, we need to understand the issue of contracts. Not all hospitals, there are different kinds of contracts given to health facilities by NHIF. And you have seen the cry recently is that people have said, ukiwa na NHIF, hautaonekana. Why? Because NHIF, for instance, has failed to honor the contractual agreement. They had agreed that this will be the amount of money given to facilities. They haven't given. And therefore, even the monies to run that facility, even to provide services for NHIF patients, is not there. So what do people do? They revert back to the out-of-pocket payment. So it is important to streamline NHIF so that even the facilities it has entered into contract with, they get paid on time, you see, and also get resolution of some of the disputes that may be there quickly, so that we do not go into that back and forth, which ends up hurting the person who is supposed to get services from NHIF, who is the client. So it is important that the public pressures the NHIF to actually pay those facilities that they owe money, so that they can run facilities. Otherwise, it becomes that the facility is the one financing NHIF as such. So maybe when we go back to the other questions, we can go further. But more importantly, also, is about quality of service. It's one thing to be able to reach a hospital, but it's another thing to ensure that the hospitals or the health facilities have the necessary health workers who are qualified enough to provide care. Secondly, that there are medications and all. Some of the problems we face is that the packages, in quotes, given by NHIF push people to, so some sort of substandard care. Therefore, if you are given this amount of money, which is not enough to recover your what you have spent, then there is you can be forced into going into ways that will lead to substandard care. So it is important also to see the packages. One of the most contentious issues that we have is the capping of that what they usually say, you can go, but you are not supposed to add money. But what happens when the cost of that care is more than that? So people may take shortcuts as a result of that. So one of the recommendations probably would make from the top of the head is that maybe there should be no capping. The NHIF should be used it pays up to where it can pay. And then if someone needs additional thing, then some of that money can be added. So there are many things we can talk about, but I think we'll let others ask questions we can answer. Thank you very much.
Thank you very much, Daktari, for those insightful comments and your presentation. Just as you speak, I get this thought in my mind that, is it about time that we make hospitals have transparency as to the contracts they have with National Hospital Insurance Fund? For instance, for outpatient services, they should have something on the charter, on the service charter, to say, yes, we are NHIF accredited, but to this extent. We can only treat you up to 1,000 shillings. We can only treat you up to 20,000 shillings. Because one of the issues we've had is that patients get to hospitals, and most of them have been private hospitals. And then what you're told is that NHIF can only cover 1,000, but this is verbally. What about we have this on the service charter, so that by the time you're entering the hospital, you can already see that if I'm coming to this hospital, my limit is already 1,000. But not to belabor on that, I want to allow the public to air their views and questions. I can already see some hands up. Our colleagues, if you can allow, I think the first one was Tabitha Ngure, and then I can see Mohammed Muyonga. I can also see Christine Sadia. Those are 3 hands. And then on the chat, I'll keep checking for questions on the chat. But if we can allow those 3 to, now I see 4 hands. Wow, there's Mohammed. Yes, so Tabitha, I think you have the mic. You can unmute yourself and ask your question. Tabitha Ngura, if you can hear me, you have your hand raised. If you can just unmute and ask your question or give your comment. All right, we could go to the next one as she prepares. Mohammed Muyonga, you have the mic. Mohammed Muyonga.
I don't know if you're getting me.
Yes, we can hear you. Mohammed, you are muted just in case you're speaking.
Yes, okay. I don't know if you're getting me.
Yes, we can hear you. Please proceed.
So mine is very simple. For example, we are complaining about NHIF. There are some factors that we need to consider. One is, for example, the capitation. NHIF is capitating people at 83 shillings per month. So you can imagine, a patient is coming to facility. You've been given 83 shillings for this patient in a month. You see this patient today, he comes with a cough. Tomorrow, for example, if she's a female, she comes with UTI. The other day, she comes with the, for example, malaria. Like for me, I'm in Busia. So you realize the insurance is expecting you to treat a patient with 83 shillings. You see how impossible it is. So my input is there are a lot of loopholes that NHIF needs to look at. One of the loopholes that NHIF is losing money to is the EduAfya. You look at, for example, we have 600,000 students who are at high school. So you realize NHIF, for every visit this child comes for, is paying you 1,000 shillings. So do you know what most health facilities have done? They go to pick these students from school. So you find that in a day, if a facility is going to see 100 students, and most of the time you find these students are not sick. Unapata mtoto, the facility has liaised with the institution. Are we together? So you find that they pick these students. At the end of the day, the facility gives the school some amount for giving them student. But you find the ideal reason why this program was started is for any child who is sick, this child is supposed to come to the facility, not to be picked from the hospital. Are we together? So you find that if we are going to treat, for example, 200,000 school students per day. That equates to something, a good amount, if you can do the arithmetics. So you find that this money, if it could have been used properly, for example, to add to capitation. So rather than giving 83 shillings, this money is added to individuals' capitation to raise it even probably to 200 shillings. You'll find there is benefit. So rather than you find when a patient visits facility, it is very hard for them to access these services because of what we get back. Then another discrepancy that comes with the NHIF is as per level. You find that there are hospitals that are being given 2,000 for admission per day. There are those that are getting 4,000, and that the level, the money is given as per the tier of the facility. So for example, these local facilities treating patients, the same malaria is being given 2,000. There is another facility, we say that like level 5, treating the same malaria is being given around 4,000. So you see that discrepancy that is there. Are we together? Then another thing on, the report is very good. One of my issue is always we say that reduce the rate. I'm against it. Do you know why? Every individual on your income, you must pay a given percent for your health. So my issue is, for example, we have low income earners. My point is always, let us do evaluation for these people. Like, for example, you have a maid who is earning 2,000 bob. So my input is always, what are they contributing? So like you'll find like if this person is a low income earner, he's earning 2,000 bob. Why don't they just pay 100 shillings sorry, for their health? Are we together? So at least there is something they contribute. Like for the asals, those are the herders, au watu wa kuchunga hawa. So like the Turkana, the Borana, and the so. The government should come up with a program. For example, you do valuation for an animal. Kama ng'ombe moja, you can evaluate it at 20,000. You see, if paying for NHIF itself is 500 shillings per month, so you find that the whole year it is 6,000. Are we together? So you find that if this person releases one cattle, which is valued at 20,000, you'll find that this person has paid for 3 years insurance for him and his family. Then another thing that we need to do, because these people are migrating from one point to another, they should not have like, you know, for NHIF, you have for outpatient, you select a facility if you are paying for yourself. For these herders, how do you pastoralist communities, their NHIF should be open in that they are treated anywhere. You see, it will be of benefit to them. So somebody gives one cow, him and his family are covered. He gives two, kama ni mbuzi au wawili, him and his family will have been covered for 2 years. Are we together? So also another thing that the community needs to understand is the NHIF needs to sensitize the community. Lack of information. It is so bad. So people should know what NHIF can offer and what NHIF cannot offer. Are we together? You find that sometimes your patient, you have NHIF, you have a patient who needs ICU services, you'll find NHIF is not covering. So this person must learn that they have to dig from their pockets. You find another challenge that we are facing is like family planning. NHIF doesn't cover family planning. Are we together? So there are things that components that the insurance should also come out and tell us this and this we are going to cover, this and this we are not going to cover. But most of importance is the loopholes that NHIF are having. You find that in the report, previously it was said some people are being forced to be admitted. You see, every facility is trying to raise its capital. The more capital you have, the more you can pay your workers, the more equipment you can purchase. So you find sometimes they're not doing it out of bad will, but sometimes it's out of goodwill and attack to that money to enable them operate. Are we together? So transparency is a must and accountability is a must. But the loopholes where NHIF is losing money, we have the EduAfya. That thing, it should be revised actually. Because now, another thing, you find that your parent has, for example, a parent has an NHIF. Sindio, these children are enrolled in NHIF. The same children are having EduAfya. So this is, at the end of the day, NHIF pays capitation for this child, which is the 83 shillings. Then if this child again is sick, they go to the facility and use the EduAfya, which is paying 1,000 shillings. Don't you see that is double? Because there is the capitation for this child, then there is 1,000 boba for this child. That is double payment for a same individual. Actually, I believe some schemes are for the poor people. Let them remain for the poor people. You see, like Linda Mama, it was made for women who cannot pay, but you find there's a woman who has an NHIF. At the same time, when they go for the antenatal services, they are registered under Linda Mama. So you find that this person has two insurance, which is very wrong. I believe like Linda Mama should be for those people who can not pay completely. You see, those are some of the loopholes that NHIF are losing money. So we need to evaluate which these loopholes and cover them. Thank you.
Thank you, Mohammed. I was about just to alert you that we also have other participants waiting to speak. So I still see Christine Sadia, Mohammed Farid. If you could have mics. Christine Sadia, you have the mic. Could you? Yes, please proceed.
Yeah, thank you very much. I hope I'm audible.
Yes, you are. You can hear.
Yeah, thank you. And thank you for the people who have done the research, and for Amnesty International for bringing this conversation at this particular time. I would like to start and buttress with what Dr. Ravi and Dr. Kagondu has said, that we are using wrong models. I think we Kenyans have not come to a conversation of what is UHC and the vehicle for reaching UHC, and what is NHIF. NHIF was originally, historically, was a department within the Ministry of Health. As I knew it, before it became a parastatal, because I was in the Ministry of Health. So it was a department within the Ministry of Health. So if you look at that, I'm not going to go to the historical evolution of NHIF, but it has been made to some animal that now is not being understood. And I think I want to start from there. But because I represent Kenya Medical Women's Association, I would want to look at the issues of whether NHIF is reaching the majority and cushioning women. If you look at those two concepts, the UHC concept, which is supposed to give to, and then you look the rights to life, the Constitution, Article 43, then you find that Kenyans, we are well educated, but we have not put our thought process quite well, because those concepts are conflicting. The right to health is in the space of the government. Therefore, the tax-funded scheme, like Dr. Kagutu had said, is the right model that we should do. The vehicle for delivering it, I do not know. But when we said that even the rural people, that we educate them, that they fund NHIF, that everybody, you make NHIF mandatory. Are you really right in your right thinking that we are in a UHC mode? Or people are collecting, we are fundraising for, the communities are fundraising for NHIF. I think that is a critical question that we need to apply our heads to. And who is losing out of this? We had said that the majority, 85% of those people who are being branded as poor, the majority of them are women. And they are the ones that are accessing services. If you look at reproductive health services, look at the burden of the disease. Is that NHIF operating even in their packages within the burden of disease? Because NHIF is more curative than preventive. At what point will we break even and find that the being healthy and people to be helped to be healthy, not to be sick, but NHIF is promoting being sick. And hospitals are becoming to a mindset of that they need to treat people who are sick, and it's encouraging people to build hospitals because they are getting money. And the issue of corruption lies therein, squarely therein. And I think the previous speaker had said they would do AFIA, the duplications, and that we are going through. It is not that it is not known. It is known, but it is a clever scheme to skim Kenyans out of their money, particularly women. I will want to say more women in Kenya. I think the majority of women, if the catastrophic, UHC is supposed to prevent you from catastrophic spending, then some people should not even be paying, because the pool and way of pulling resources for health financing, which Dr. Kagundu said, is premised on the fact that those who are able to pay will pay for those who are not able to pay. And when somebody says that capitation is 83 and you go to hospital every day per day, it is premised on the fact that not people attend hospital. A very small percentage of the pyramid should be able to go to hospital. The rest of us should be healthy. And I think Kenyans need to go to the conversation. At what point are we getting the right model that will service Kenyan people? Thank you very much.
Thank you so much for your contribution and bringing in the gender perspective to this. We have McDonald's, Shiundu Marion Ouma, and Franklin Ochieng. Okay, McDonald, you have the mic.
Thank you. This is McDonald from Mumias. Yes, I would like to say thanks for this meeting, and the report is actually eye-opening. We really appreciate. But I would like to to give input concerning how the funds are managed, because it's really discouraging for a Kenyan who is really struggling to contribute. But at the end of the day, you hear highlights in media how corrupt officials of NHIF are. It's really hurting to hear the secretary at NHIF is moving with a chopper, with the Range Rovers and the rest. So you feel the pain, and it has really discouraged most of the Kenyans to contribute towards these funds. You realize that you say, after all, itaibiwa. So there is no need, people are not motivated. You like the government to come up with policies that are strict on the management of these funds so that Kenyans are able to get services and they'll be encouraged to contribute, because the money is getting lost. When you go to the hospital, you're being told that we can't admit if it's NHIF. It means the institution is broke. So we humbly ask the government to tighten the belt when it comes to the management of these funds. Thank you.
Thank you so much. We have Marion Ouma. Admin, if you could give Marion the mic. Marion, you have the mic. Please proceed. Marion, if you can hear us.
Yes, I can. Can you hear me now?
Yes. Karibu.
My name is Marion Ouma. I'm a social policy researcher. And I believe issues of health, as much as they are medical also, a huge part of it is social. And actually thinking about universal health coverage, then you're talking about a social policy instrument that then a government rolls out for its people. And I think the aspiration that we have of UHC and looking at what NHIF is, I think, and a lot that has been said about NHIF, I'm not sure why one of the recommendations was not to disband NHIF, because I think NHIF actually has outlived its purpose, and it needs to be disbanded. And it's not the vehicle that will actually, will actually deliver UHC. And so I think this is something we don't say, people don't say a lot, but actually NHIF needs to be disbanded now. It's become a cash cow that's actually just taking money out of the Kenyan public, but it's not providing healthcare, the right kind of healthcare. It's not managing the right kind of healthcare for people. That said, I think it's been discussed. I think there's been the issue of the taxpayer model, which I agree with, but also I have asked, how can you have counties administering different models of UHC, as was recommended in recommendation number 6, when, yes, as much as you have a taxpayer model, it has to be from a single payer, which is a public institution. Because if you don't do this and you have multiple agencies that are payers, then you start experiencing and entrenching further health inequities, and you have different kind of health outcomes within counties and so on, because counties have different capacities. And so this is a question I'm asking: how then do we reconcile that we have a model? If you want to achieve UHC, we need a model that has a single taxpayer, but then on the other hand, we have health as a devolved function. health as a devolved function, with counties having to run their own health budgets. And I think something that has been said about leaving some services for the poor, and from a social policy perspective, and I think it has been mentioned by the previous speaker, you cannot have, UHC and healthcare should be about solidarity and collectiveness, you know. It should be about those able to pay, supporting those who are not able to pay, so that you have an equitable distribution in terms of provision of services. And so you cannot segregate and say these are the services for those who cannot pay, these are the services that they don't have, and there's those who are able to pay much, these are the services that you will have. Services, what we know over time and what we know is that when you desegregate and you say these are services for the poor, they will remain poor services. Because for issues of social policy, issues of healthcare, it has to be about, let me say, people carrying each other. Yeah? It has to be about solidarity, working with each other. And so the moment you say these are services for the poor, what we are doing is we are saying poor people, or poor people who are only able to pay a certain amount will have poor services, and that's what will continue to happen. And I think I've had some discussions before about UHC, and people, and I think it has been mentioned that we've not had that discussion as a country. And these discussions are happening, but I think the spaces that they're happening in are not accessible to Kenyans, yeah? And you see all these conferences on UHC, and they're happening in big hotels, yeah? They're happening in big hotels in the country. And you have, I mean, it's all glamour when people are talking about UHC. But I think we need to come down to, this discussion needs to be brought down to everyone so that we know it's about solidarity. We are all contributing to this. We're all talking about the same thing, rather than having debates and meetings in hotels where you're having people discussing, actually saying UHC for women, UHC for youth. You cannot have UHC for women and UHC for youth, because the word universal by itself means it's for everyone, yeah? So having that segregation that's happening and people having meetings about UHC for women, for youth, UHC, it's UHC for all, universal, all Kenyans, the whole population. And I think that's how we need to have the conversation. Thank you.
Thank you so much, Marion. And we take note that we need to bring these conversations closer to the people. We have Sylvia Konzi and Franklin Ochen. Franklin, you have the mic, please proceed.
Hello, Zaina, can you hear me?
Yes, we can hear you loud and clear. Please proceed.
Thank you very much for the opportunity. I was just agreeing and also the contributions of those who spoken. First, I would like to talk to those who are in the field of health on how they can work on creating awareness on NHIF that operates, because the NHIF policies are only known to a few, and that's why we cannot have a good number who are benefiting from this, most of those who are living in the countryside. I also support that that NHIF should allow people who cannot give money to give, like present, like say items, the way you said, the cows for the nomadic community, for the pastoralist communities, to give items so that they can be facilitated. And I don't agree with those who are saying that NHIF are programs for the poor, because there are so many countries that are working with the same institutions such as NHIF, and they are doing good. The health services are good. In fact, sometimes we get out of our countries to get there and get good health facilities. I lastly thank the Amnesty International for bringing this engagement, and thank you, the medics who are in. I dream of a Kenya where there will be good health, and there will be good health by dint of the services that are being offered by the institutions such as NHIF. Thank you.
Thank you so much, Franklin. While we may differ in our opinions, we do respect each and everyone's opinion in this platform. Sylvia Konzi, you have the mic now and you can proceed.
Thank you so much. My name is Sylvia Konzi. I am speaking as an advocate of the High Court of Kenya, and from where I sit, I want to appreciate the discussion that is before us. I also want to appreciate the discussion that is centering on the social aspect of it, the economic aspect of it, but I want to talk about the legal aspect.
Sylvia. Have we lost Sylvia?
Yes, Zainab,
Yeah.
she dropped. Yeah.
Okay. I think as she tries to make her way back, we can listen to Nelly Bosire.
Thank you. Good morning, everyone. My name is Nelly. I am an obstetrician gynecologist. I think my contribution would probably be whether we actually think that what is paid to NHIF actually covers the true cost of care. Because always think that if it's universal health coverage, it's cheap. It doesn't change healthcare. A pair of gloves isn't going to cost any less because medication won't cost any cheaper because now you're in UHC. The question is, what we are putting aside as capitation, is it truly going to cover the cost of care? And I'll use free maternity as an example. Free maternity pays about 6,000 shillings for a normal delivery per institution. Now, if you're paying this to a public health facility, it makes sense. It will be able to cover for the consumables that are going to arise out of the delivery of this mother. But what we don't appreciate is that the healthcare worker in that facility is not paid from that 6,000 shillings. Not the midwife, not the doctor who is going to attend to this mother. Their salary is coming from a completely different pot. Now translate this 6,000 to a private health facility, where all these consumables have to be covered in the 6,000, including the cost of paying that midwife who is taking care of the mother, the doctor who may have to step in case of an emergency. What does this translate to? It literally translates to poor medicine for poor people. And that's why you're seeing a lot of facilities opted out of the Linda Mama program, because they actually understood that what has been put aside per patient is not enough. It's not going to be able to cover for the cost, and they cannot be making losses on this. So this is something that nobody is paying attention to. And so we end up compromising the quality of care. There has been a lot of harm done in these small private hospitals that are actually taking care of pregnant women under the Linda Mama program. In fact, the mother is far safer in a public hospital. And this is something that we don't have an appreciation for. So when we talk about a lot of NHIF money going to private hospitals, we have to actually think about this and wonder whether this has been thought out correctly. The other thing that in NHIF that doesn't make sense to me as a doctor is why we do not have a standard cost for procedures. If you take a Jubilee insurance, it is going to tell you your maternity cover is going to be 150 or 200, depending on what you negotiated on your cover. This amount is not going to change whether your delivery happens in Aga Khan or it happens in Nairobi West or it happens in Kenyatta. It won't matter. Why has NHIF been unable to give a fixed fee, which even the client knows? For me to have my fibroids removed, it is going to, the NHIF is only going to cater for 150,000 shillings. And then I decide, based on my pocket, let me go to Kenyatta where the total cost will come to 130 and I don't have to pay anything out of pocket, or I go to Aga Khan and I top up an additional 200,000 and literally I get the same service, but maybe I'm paying hotel service for being in a fancy hospital. But the quality of care then doesn't change. So you find a patient going for the same procedures, literally begging NHIF to increase what they will pay. Corruption, corruption, corruption. The end user, the person suffering is the patient. And we have said, these are pricings that Kenya Medical Association and all the other professional associations sat down and negotiated with NHIF. They should be even gazetted. They should be public figures so that patients know this is what I am entitled to. And it's up to me to decide how I choose my care to cover these costs for me. So we're having so many challenges with NHIF, which it doesn't take a genius to understand how they can be fixed. What we are seeing is that it's intentional sabotage to keep the public unaware of what they should insist on having so that their services can be smoothed out. We need to see this. We need to see some uniformity. And one of the reasons I believe the government doesn't want to do this or NHIF doesn't want to do this is really because then they have to fall back to calculating what we are paying out vis-a-vis what we are collecting. Is it making sense? So whichever mode we choose to fund NHIF so that NHIF funds healthcare for all, it has to first of all start by understanding and accepting that healthcare is not cheap. It will never be cheap. Countries like the UK that have offered universal health coverage, I promise you they spend a huge chunk of taxpayers' money to fund that. And the quality of care is dependent on how much you put in. So you are going to have to expect them to be strictly regulatory. There are things that most of these countries have put in place that Kenya hasn't even started before they can guarantee universal health coverage. They're not paying for every service available. They're very clear about what services they'll offer. They're not going to have a patient seen wherever they like. They're going to say, you will start from primary healthcare if it's not an emergency, so that we minimize undue costs, undue expenses. The second thing that I would like to pay attention to is that investing in preventive care does not mean that we stop investing in curative care. Our diabetes isn't going to go down because we've invested in primary health care. Our cancer cases will not reduce. The only thing we're looking at is how do we get these diseases early? How do we manage them better to reduce complications so that the overall cost of care comes down? So I keep hearing this, invest in UHC, primary health care as the focus, but we're not looking at curative because they have to go hand in hand. If you have a referral system, both the primary facility and the referring facility, they must work for the system to be effective. It's the same thing. We start with primary healthcare. Yes, we must strengthen it, but it is not at the cost of curative. So we are not going to reduce the budget in curative care so that we put it in preventive care. We have to think about where else we get additional funds to fund preventive care and give it 10, 15 years before we begin to see the impact on reduction in curative care. Those are my contributions. Thank you.
Thank you so much, Dr. for those insights and the nuances that you've observed in your practice. Just for the record, we sent the right of reply letters to Ministry of Health. We also sent the same to NHIF, but we haven't yet received any responses. So just in case you're wondering why you're not hearing any of their voices, well, we did our best, we did our part. So I'd like to take if you could please make your contributions or comments brief, and then we also check on the chat and question and answer, because we have now, I see over 40 messages that we have not read, and then we'll go back to our panelists to just hear what they have to say about the contributions coming from the public, and then we say that we have officially launched and close it at that, but we are also taking note of the recommendations coming from the public saying that we need to take this discussion closer to the people. And I am sure NHIF and Ministry of Health must be listening in from somewhere. So the message is being heard. And if you have any further engagement that you wish Amnesty and PHM and all other partners involved to join hands with you so that we can bring accountability in the health sector and insurance sector, please reach out to us after this. So we please do have two more. I request for just two more very brief comments or questions before we go to our messages. Thank you. So Jeva Sobutu, you have the mic, please proceed.
Thank you so much. I'm Jeva Sobutu. I'm speaking from Kisii. I'm a journalist by profession. Now, I think in Kenya, we generally have a problem with parastatals because if you look at KPLC, we have the same problems that are reflected with to NHIF. So speaking on NHIF, I think the problem is not contribution. The problem is not like the how it's set up, like the whole thing. The scheme is really pretty nice. The problem is value for money. I mean, the contribution that you're giving vis-a-vis the services that you're getting, that they really don't tally at all. For instance, if you happen to go to a hospital and one person has money and you're going to with an insurance cover, trust me, you wouldn't get the same services. Reasons. These facilities complain mostly that, you know, we are going to give you services and at the end of the day, we are not sure if, you know, NHIF will remit monies that, you know, we will invoice them. So the whole system has a problem. And if NHIF will be honest, you know, and become human enough, because I know that their representation, you want to work up at the same time. If they become human enough and, you know, revert to its original course so that it doesn't become a money minting project, we will enjoy good services. Secondly, I think there has to be a way that has to be found so that, you know, our private facilities, you know, should be regulated. You can go to even a private hospital and then you have just a minor problem, say malaria, or say you cut yourself somewhere. By the time wanakumalizia, I tell you the bill will be exorbitant. You just have a very small cut and then they'll bill you 10,000. Why? They feel like this is the only opportunity that they can make it, you know, they can get this money, so they'll milk it. So I feel there should be a way that, you know, these private facilities should be regulated. Bottom line, NHIF is awesome, but lazima warudi nyuma. You know, the primary reason why NHIF started, we should be reminded. And if at all they mean it, hizi maoni zote tunatoa, they should honestly also consider them. Isikuwe that we are just, you know, having a beautiful conversation, you know, giving recommendations, asking questions, some get answered, and then nothing is done. I think it would not be fair for time spent. So if public participation will come into play, then let every opinion matter and let every suggestion be put into consideration. That is what I would say. Thank you.
Thank you so much, Javas. And yes, there was a public participation invitation for the NHIF Act Regulations 2023, and Amnesty submitted its comments on specifically 13 clauses that we felt were not helpful to the common mwananchi, including that which those not employed will be required to pay 1,000 Kenyan shillings instead of the 500. So we have submitted our comments on those regulations, and we hope that they will be factored in I will then take Jerusha Anyango. Alex Okaya, if you don't mind, please put your question or comment in the comment section in our question and answer so that then we can look at that, because I feel we have a lot we have not captured in our messages and question and answer section. Jerusha Anyango, please, your brief comment or question. Thank you. Jerusha Anyango, if you can hear me.
Hello.
Yes, Jerusha, please take it away.
Yes, me, I was asking, nowadays, when you don't contribute every month, NHIF, they are the penalty fee, which is 250 shillings. So how can you handle that? Okay, I'm done.
Thank you, Jerusha, for your very brief question. I'm sure at some point it will be addressed by our panelists. But first, I wanted to check the question and answer section. All right, so Emmanuel Obwanga says there has been an issue of accessing NHIF health data, like someone would wish to have a BQ of how much has been deducted from their NHIF account placed in white and black, but sometimes this is not made possible. Is this attributed to some loophole in the health data privacy access policy? So I'm reading out, and our panelists will be able to respond to some or all of the questions. So this one is to Raviram. Nelson Onyimbi says, Raviram makes sense. That section out of the general population serviced by private insurance has better health, almost a euphemism for the tragedy of the commons. Salim Ochango says, this year's Mashujaa Day theme is on universal healthcare that will be launched during the celebrations to be held in Kericho. My question, have the experts been involved to make the program realize its goals through NHIF, or is it just a rushed program? I'm sure one of the panelists will handle that. Regina Ndambuki says, I hope we will receive the presentations because some of us had challenges with network. Regina has provided their email right there. We will definitely provide the recording on our social media networks and our website so that you can always listen to this. And John Ebenyo says, how do we employ social accountability in institutions like NHIF? And John, okay, then again, John Ebenyo says, though 500 is paid, the question is, how many people are subscribed? Those subscribed, how many go for treatment? In my view, 500 shillings is adequate. Well, whether it's adequate or not, Zaina cannot determine, and I'm sure the experts in here will help us. So, oh wow, we have over 50 messages. So maybe I could allow for the panelists to first respond to, of course, we've had the verbal comments, questions from the public, and we've also seen from the question and answer section. Dr. Simon, I see you're very ready to engage and respond to some of these questions and comments. So I will allow you time as we gather what we have in our chat. Thank you. Karibu sana, Daktari.
Oh yeah, I was hoping Ravi would go first since he had the right to reply. Is Ravi around?
I can see Dr. Ravi. There's a request that you go first.
Happy to hear Dr. speak first.
If you can hear us. Sorry?
Yes, Zaina was just saying happy to hear Dr. go first, then I'll add my piece.
All right. Thank you.
Excellent, excellent. Just to wrap up, I think you've had the presentations from especially Dr. Nelly Bosire, and that happens to be a view across the medical profession. Granted that the medical workers fall on both scales. They are both patients and they provide service to the wananchi, and they see the problems that wananchi face, especially when they come and you're told, oh, your NHIF card is not working, your NHIF card you haven't paid for. Then we have been able to engage NHIF for a long time. If I start with my organization, the Kenya Medical Association, where I am the president, we are by law board members of NHIF. So all these bashing of NHIF also includes us. And therefore, occasionally we have to say what we have done. And for me, it is important. One of the reasons we wanted to be in the board is to be able to provide the voice of the medical profession and voice of Mwananchi in the board. And if you look at some of the changes that have gone through NHIF, by the way, NHIF now is much more, in quotes, comprehensive in terms of service delivery than it was before. Prior to that, they used to pay for the bed only. But following advocacy from the medical practitioners, then we added things like surgical packages, whereby NHIF could actually now pay for your surgical or dialysis packages. These were recommendations from the health workers because it did not make sense for you just to get your bed paid for and the service has not been admitted. After that, now they, in terms of a lot of medical personnel, also run health facilities. When the health facilities, as was earlier alluded to, the costing of some of the services that NHIF, in quotes, wants to pay may actually be an avenue for substandard care, as has been alluded to before. But what is the solution? The solution is not necessarily for NHIF to pay the whole amount. It is for NHIF to pay what had been agreed upon. And the health workers had actually gone to a meeting to discuss this cost in 2018. And when these are not adhered to, it causes a problem. Sustainability, again, what is the sustainability model for NHIF? NHIF, I said, operates like any other health insurer, meaning that it receives money and that's the money it budgets for. So because health is a social good, we actually need to look at it from a different perspective. We actually need to say that NHIF cannot actually pay for all healthcare costs. It's too expensive. And therefore, what is collected by NHIF, yes, should be utilized wisely. We need, of course, to institute some of the recommendations of the report, streamline the NHIF processes, which are ongoing. But also, we also need to look at it from, as we have said, tax-funded healthcare service delivery. If we go back to education on taxing, the Abuja Declaration said that 15% of the budget should go to health. And this is the amount of money that should go to boost NHIF so that when there is a shortfall, you are not told, oh, out of pocket payment. So we are currently at 6.9% of healthcare financing. So of the budget, only 6.9% is spent on health. Therefore, if we increase allocations to health, then NHIF will stop having some of these issues that it is facing. Then we also need to improve the efficiency of the services at NHIF. But finally, we as Kenyans need to go away from the concept of poor medicine for poor Kenyans, as alluded to. So whereby you are having differential kinds of treatment for people who are poor, so to speak. We need one healthcare system that is well equipped, has adequate numbers of health workers, and is providing the highest level of care, so that we avoid this, oh, I was told I cannot be treated for this, and so that we have a uniform package so that everyone who goes to the health facilities gets the highest quality of health care. And therefore, our appeal to Wananchi is one, when the report is launched, let us read it. It has made very good recommendations on what NHIF will do. And two, we should advocate for the highest quality of healthcare at all levels. And this is pushing the government to employ more health workers, pushing the government to make more, the various governments to make more health facilities so that their access by Wananchi is near, and also to ensure that we hold the NHIF and the government in particular into account on the use of money meant for health. If money is meant for health, it should be used for health. When it is diverted, people stop having good healthcare. Let me allow Ravi to continue. Thank you very much.
Thank you so much, Dr. for your feedback. Ravi, thank you.
Sure. First, let me start. Can you hear me okay? Make sure. Okay. I very much want to appreciate what Dr. had said at the very beginning. He's part of KMA. He's part of the board of NHIF, and he's putting himself on the line. I think that's very important. And it's worth also saying that all of us are on the line, our families. We all depend on the Kenyan healthcare system. And as Dr. said, we need one healthcare system well equipped with adequate healthcare workers and uniform health quality services for all. Let's keep in mind that I've seen some of the debates on the chat, and some people are defending NHIF. One person is working there. Glad we do have you here because we need all the voices. I think something we can all agree is that the current model is only partially working for those who can pay for health insurance. And that includes those of us who pay our NHIF subscriptions. And that's when we look beyond to all the people of Kenya, we have to say the system, not just NHIF, but the system is utterly failing our people, and especially those who cannot pay. So let's think more creatively about not defending a system that's partially working for people who pay, but what kind of system will work for all people and provide all the kind of services, like Dr. was saying. Second point I just want to make is that NHIF, as it is, covers clinical care. It waits till you are diseased or sick, and then it comes in. But we know that health produced and disease is produced from outside of. And by that I mean some basic things. We need preventive care. We need health promotion, other forms of disease prevention. And those are not profitable. We can't look to the private healthcare system and say, let's take that on too. They simply don't generate enough revenue. And that's why we have a government. It's for the health and well-being of the people. If our government is not going to step up and make sure that we do not get sick, but instead have a partial system to pay for some of us when we do get sick, then we need to change what the government's doing. That's the real question of health policy. It's just about how we're going to move money around and cover this or that for some people or all people. It's how we're going to make sure that we are healthy as can be, not just somewhat covered when we do get sick. So let's keep that in mind. Disease prevention, health promotion, those are the real foundations of a functioning healthcare system. It has to be public because it's not profitable, and the private healthcare system will not touch it, even if the majority of our people could pay. Those are just some final points to wrap out. This is an excellent study because it's putting it forward. What do we want to see as the next steps for NHIF? And Zaina, I know that you had a specific question you wanted me to address. If you can just prompt me or remind me what that question is, and I'm happy to address that as we begin to close this webinar.
Thank you, Dr. So I have been trying to check from the chat because some participants have posted comments and questions in the chat instead of the question and answer. But one of the questions I've seen from Chris Oyo is, they say, what other role does the government play other than appointing members of the board who he alleges have been corrupt in the rebates? I don't know whether you can answer that question.
Sure. I don't want to address that. I don't have the specific information. I do share some of your doubts, but that's as far as I can go. I think what you're pointing to, though, is the need for stronger social accountability. Dr. Tardia said he's on the board. He can do what he can, but he has a full-time job of his own, as do other board members. And let's not pretend that simply having members of a board who receive papers produced by any organization can satisfy full public accountability. So there's much more that needs to be said on social accountability. I'm a strong believer in it, but I'm not necessarily the expert. I think, Chris, you raised a very good question. I know somebody else has, I think Benyo had also raised a question, how do we employ social accountability for NHIF? I think one of the points we can leave here is that this report has brought us to a stage where we can ask these questions. We need to have, it's not the be all end all for the findings and recommendations we have. We're just to the next stage. And let's make sure that social accountability and health is in the forefront as we look for what we want next from NHIF and then our national and county government.
Thank you so much, Dr. Ravi. Just to remind all of us that we can take on this conversation on our social media spaces as well. And our hashtag is Afya Nafuu, because we want affordable health for everyone in this country. So I'd like to take back the mic to our board chair just to give us her final reaction before we get to have our executive director at the moment, Levi Muley, to have closing remarks, and we call it a wrap. Awal, if you can hear me.
Thank you, Zaina. Wow, that was such an insightful conversation. A lot of good questions that came up out of this conversation. A few things that have stuck with me as well outside, of course, the more obvious points of transparency and accountability. It's just how far back we still are in terms of realizing health equity or equitable access to health, and some of the realities in practice for doctors, for other medical practitioners. I saw comment in the chats asking about how do we also integrate independent labs into this conversation. Some of them also have, or healthcare practitioners outside the more mainstream medical field, and how do we integrate them into this conversation, because they're in some ways also affected by this. And that was an interesting contribution. I think there's a lot to be done, but I think one of the things that we have to continue doing is speaking up about these issues and contributing when we have opportunities like this to voice these concerns. It was such and I learned a lot myself, not anywhere near the medical field. And I have to say, it has also deepened my understanding of how NHIF works as a model. And thank you for convening us. Thank you for putting this report together. I'm actually looking forward to seeing how we can engage further with the points that have been raised here on this subject. And thank you so much, Dr. Raviram and Dr. Simon Kigondu, for your insights and just the wealth of knowledge you have on this. And I hope we can keep this conversation going and push for changes in our medical sector towards realizing equitable access to health. Thank you, Zaina. Back to you.
Thank you so much, Awal. So I'd like to invite Levi Mulei. Are you here yet?
Yes, I'm here. Can you hear me?
Yes, we can hear you.
Okay.
Please take it away.
Yes, thank you, Zaina, for this. First, I want to thank all the participants that attended our launch today. It's not easy getting people for 2 hours virtually in such an occasion. Well, as most of our colleagues have said, the purpose of this research is to find ways of strengthening the institution, that is NHIF, and which would in turn ensure that Kenyans get good healthcare services. From the conversations that we've had, there's a lot to learn. It was smooth to hear Dr. Kigondu and Dr. Ravi delve deep into the conversations, very eye-opening for some of us. I would like to thank the Amnesty Kenya staff, specifically Benta, who was the lead researcher in this, together with the inequalities team led by Zaina and Lavenda Namdiero, also assisted by Ashraf Aziz, Janice James, and George Wainaina. This was their work. They traveled to all the counties, collected the data, and put out this report. We would like to immensely thank you. Our board, led by the chair who is here, Wara Yecho, and part of the panelists, Simon Kigondu, who is also a board member, and Kevin Mwachiro, and any other board members that are here. Thank you for your oversight to Amnesty Kenya. We appreciate the support always. Our publishing partner and research partner, People's Health Movement, we appreciate your contribution as well. And we hope to do this again and continue the conversations. Of course, we have other partners that worked on the periphery on this, specifically the KMPDU, the Kenya Union of Clinical Officers, the Social Justice Center Working Group, East Africa Civil Society Organization Forum, Gifted Community Center, and Collaborative Center for Gender and Development. Please feel appreciated. We'd also want to thank our COCs, specifically COCs from Tana River County, Garissa, Wajir, Kisumu, and Kilifi, who participated in this research. Please feel appreciated for your contribution. To all participants, we also thank you for attending our meeting, and we hope you enjoyed attending our event as much as we enjoyed putting up together. And lastly, let's keep the conversation going. Let's head over to our social media pages and further the conversations. The hashtag is Afya Nafuu. And as a call to action, as Kenyans, we need to see meaningful and deliberate reforms at the NHIF. There's been a lot of conversations, both online and offline, about what's working and what's not working. Please, we urge you to take these conversations seriously and ensure that the policy reforms are instituted. Lastly, for some of you who are not AIK members, Amnesty Kenya members, we take this opportunity to invite you to register and be our members. Please head to our website and register. Thank you so much. Over to you, the MC. Lavender.
Thank you so much, Nyamo. That was a very, very short and sweet closing. And I also love your call to action that this doesn't just end here, but we actually challenge our government and our institutions to adhere to human rights obligations. So I will close here. Please go to our website. You'll have access to the report. And thank you once again for everyone who joined us. So I'll say goodbye for now. Thank you so much. Billy, if you have any music for us as we head out.
Even as we listen to the music, would like to request our Constant to post the link to our website on the chat so that those who would like to access the report go directly to it. We would also like you to follow us on social media, on our social media pages, as we engage further on this topic. Thank you.
The policemen are taking position. The students are looking for justice again, drawing their lines in the sand, each waiting to see who's a man. They're choking on mounting frustration, mourning the state of the nation. Their hearts are aflame, their blood is on fire. Stones start to fly, politicians deny. Then who is to blame? Who is behind this? Who is in the shadows? Who lets the flame of this raging inferno and watches from her window? What we need is justice, justice. Will you come help me